Today we're going to discuss the common appearing vein on the anterior aspect of the lower leg. We'll discuss the etiology and the treatment of this pattern. Now, veins on the anterior leg may be actual dilated varicosities or dilated reticular veins. Spider veins are also commonly associated at the inferior aspect of the leg and also in the ankle. Now, this patient has a smaller reticular vein. It's not dilated. It's about 3 millimeters. In this case, we'd use Sotradeco 0.2% foam or Polydolconol 0.3% foam and post-treatment compression, as you'll see later, with a pool noodle. Before we do the compression, we always make sure we evacuate any trapped coagulant. In this patient, you also notice that she has psoriasis. Now, the origin of the anterior vein is from one of three sources in our experience. This may be a branch of the GSV or continuation of the lateral reticular subdermal vein, connection to the lateral subdermal reticular vein, or there also may be a true perforator from the anterior tibial vein. Any one of these three sources can give rise to the dilated reticular veins that are common on the anterior aspect of the tibia. Now, note the marked amount of spider veins that are present in this patient. It's not uncommon to see spider veins either on the anterior or medial aspect of the ankle. In the following slides, we will show you the treatment of this patient. Always remember, after treating the anterior tibia vein, the vein must be incised or phlebectomy done to remove any trapped coagulant. Now, this is the lateral reticular system, and you can see it's dilated here. It causes all these varicosities here. So in this area, we do 0.1% foam. We're going to do 1% to these larger ones, a phlebectomy here to unload this. Probably a little nick here and here to get any of the foam out after we put it in. It's pretty hard to do phlebectomies on the anterior aspect of the leg because there's not a lot of fat. So she will get a little bit of clotting here, which we can just see her back in a few weeks and get out. So we'll show you after we do this procedure, and we'll show you us doing that one as well as the phlebectomy. Now we've cannulated with a 25 butterfly. We're injecting Varithena. Let's do it slowly because you get the blood to go through, but you can see the foam, Varithena, going up superiorly. So we're going to inject a little bit more up here just to fill this up in a minute, and then we're going to show you the procedure down a little bit lower when we inject. Down lower. Now we put a pool noodle on the area that we injected on the front just for compression to try to keep some of the clot from forming after we inject. You can see under here how it looks pretty good. We're going to do a phlebectomy here in a minute. I'm going to inject this with 0.1 Sotradeco foam with a butterfly, and I'll show you that in a minute. Now we've cannulated the vein. 25 butterfly. We're injecting foam. See nice penetration. This is 0.1%. Shouldn't sting as much as Polydolconol. But we just fill up this whole complex with foam. We'll do on the other side here in a second. But this is what... Now we're going to flush, because some of this is kind of clotted. You see kind of grayish, made a little nick right there. So we just try to flush a lot of this stuff out. You can see right here, we'll make a little stab. Now we're doing a phlebectomy of this dilated vein before it courses down the tibia. This is on the lateral aspect of the tibia. The origin is the lateral reticular subdermal vein that is completely dilated all the way up to the lateral aspect of the thigh. When you do a phlebectomy, you can remove a lot of the trapped coagulum, and also you get a better cosmetic result post treatment. This is almost like doing an exit phlebectomy that we've showed you before. The phlebectomies on over the tibia are a little bit more difficult to do because there's really no fatty tissue there. However, if it's really dilated, you can do one there as well. Usually by just doing one phlebectomy is all you need after doing foam sclerotherapy. Now, if the vein is small, such as a reticular vein around 2 to 3 millimeters, which is often the case, after foam sclerotherapy with 0.2% supradecal or 0.3% polydocanol, we incise the vein about 5 minutes later with a 11 blade and express any trapped coagulum before applying compression. Now, veins that course down the anterior aspect of the leg over the tibia can range from 2 millimeters up. The size of the vein usually relates to the duration of the reflux. The origin of this vein is most commonly the lateral reticular subdermal vein, a branch of the GSV, or actually a true perforator from the anterior tibial vein. We always use foam sclerotherapy to treat the anterior veins. Now, if the anterior veins are small, it's 0.2% sotradecal or 0.3% polydocanol foam. If they're large dilated veins, it may range from 0.5 sotradecal to 1% polydocanol. Now, after we do the foam sclerotherapy and after we've either done a phlebectomy of the proximal vein or done an incision of the reticular vein, if it's small, we apply a pool noodle compression and leave it on for 2 days. If the anterior vein is dilated, as mentioned before, we will do a phlebectomy. We usually do it right before the vein courses down the tibia, since there is more fat in this location, and the dilated vein will always be present either from the GSV or from the lateral reticular system, or possibly from a perforator. Always remember to express any trapped coagulum before the compression is applied. Now, we'd like to see our patients in follow-up in about 2 weeks. And at that time, if the spider veins have some trapped coagulum, we will flush them out. If there's still some trapped coagulum in the area of the vein that we treated with foam sclerotherapy, we'll try to also relieve that, express it if possible, using 11 blade. This just gives you a quicker and better cosmetic result.